But to make up for it, I've put all of the photos in my presentation as photos from Canada. So they're actually all from Banff, from a recent trip I took there. So this is as Canadian of a presentation as I could possibly put together. I'll start with sort of a clinical scenario. If we think about two patients who are undergoing a kidney transplant, and one of them is 42 years old and Caucasian and female with hypertensive renal failure, and the other one's 68-year-old Caucasian female with hypertensive renal failure. And I ask you, who will have better outcomes after the kidney transplant? I can't hear you, but I know you're all saying that the 42-year-old will have better outcomes and that this is somehow a trick question. And obviously it's a trick question, because then I'm going to tell you that the 42-year-old is frail and the 68-year-old is non-frail, with this, mystical concept of what frailty is. But the 42-year-old is still 42 and the 68-year-old is still 26 years older than that 42-year-old. So how will this impact what the likelihood is that they'll spend 2 weeks in the hospital, which is a long length of stay for a kidney transplant? What is the likelihood that they'll be readmitted to the hospital within 30 days of discharge, and what is their mortality? Can this frailty really turn somebody from 42 years old into having worse outcomes than a 68-year-old? Or will their outcomes equalize, or will the 42-year-old still do better? Well, if we look at length of stay, there's a 30% chance that the 42-year-old frail woman will be in the hospital for longer than 2 weeks, and a 21% chance that the 68-year-old non-frail woman will be in the hospital for longer than 2 weeks. In terms of early hospital readmission, twice the risk of early hospital readmission for that 42-year-old because she's frail as compared to somebody substantially older than her, but who is not frail. And that's the only difference between the two of them. And surely this can't impact mortality. Surely a 42-year-old can't have higher mortality than a 68-year-old, but indeed she has more than twice the mortality because she's frail. So what is this frailty, and what is the interaction between transplantation, kidney disease, and gerontology? So I'm going to talk today about lessons we learned from the geriatricians. And when you're a geriatrician and you're studying people who are 80, 90, 100 years old, you need things that transcend comorbidity. In transplantation, we're very good at measuring comorbidity, but we're not very good at measuring something that transcends comorbidity, that really picks up physiologic reserve. Some people might call it sarcopenia. I like to think of it as a quantification of the foot of the bed test. So can we quantify what it is we know that a 40-year experienced clinician can look at a patient and say, I don't think this patient will do well, even though they're chronologically young, because I think they're physiologically old. So to demystify it a little bit, Linda Fried, who was the head of the Center on Aging Outcomes at Johns Hopkins before she moved to Columbia to be the dean of the School of Public Health, described a syndrome that involved 5 clinical components. So this is the clinical instrument that measures the frailty physical syndrome. And those components are shrinking as determined by unintentional weight loss, weakness determined by a grip strength test, exhaustion, low physical activity by a questionnaire which assesses physical activity, and slowed walking speed. So, 3 trials of walking 15 feet, how slow are you at walking? And it turns out that in community dwelling older adults, frailty is independent of comorbidity and disability. And you can see here in the Venn diagram, there are some patients who have all 3 of these problems, but there are a number of patients who are frail who do not have any comorbidity or disability. So frailty is this independent construct, this independent domain of risk. There is a pretty elaborate conceptual model of frailty, and similarly, there's an elaborate inflammatory model of frailty as well. So frailty is an inflammatory state, and that inflammation leads to increased vulnerability to stressors. It is thought to be related to immune system dysregulation. In community dwelling older adults, that means one thing, but obviously when we start thinking about transplant patients and the immune system, that's very close to our hearts and to what we do to our patients. And it's this heightened inflammation and alteration in immune systems. And it's associated with, as I showed you in the previous slide, dysregulation of a number of physiologic systems, including this inflammatory state. In community dwelling older adults, it is significantly associated with mortality. So these are at the top non-frail, intermediately frail, and frail older adults, just living their life out in the community, not hospitalized patients, et cetera. And you can see a substantial association between frailty. So frailty is an important construct in gerontology because otherwise they really have no way of understanding their patients because everybody has comorbidity in that population. Well, we operate on patients when we transplant them. And so our first interest in frailty was that in surgical populations. And the motivation for this, obviously, is that the population in general is getting older, and older adults are comprising a higher proportion of those considering surgery and those undergoing surgery. And risk prediction is challenging in this population. So chronologic age is often not equal to physiologic age in older adults undergoing operations. And we need to know this because we need to be able to make clinical decisions about them, like, is this operation that we are proposing to do worthwhile, or should we have medical management for that patient? But also in terms of, if we do decide to operate on them, how should we manage them post-surgically? So about 10 years ago, my friend and colleague Marty McCary and I collaborated on a study where we took 600 older adults, so they were all over 65, all undergoing elective general surgery. And we found a frailty prevalence of about 10% in this population. You see on the left column the complications from those undergoing minor surgery, and on the right column complications from those undergoing major surgery. And then on the bottom you see adjusted models where we adjust for demographics and comorbidity and disability and everything like that. And you see that non-frail patients don't really have complications from minor surgery, but if you make them frail, their complication rate increases substantially. And if you adjust for the kind of operation that they get and their characteristics, those who are frail had 2.5 times the risk of complications than those who were not frail. And this is really important because if you're frail and you're undergoing a major operation, there is a 50% chance you will have a complication. That's something we need to know about for counseling and for clinical decision making. The frail patients ended up staying in the hospital 1.7-fold more days than the non-frail patients. And in terms of where they went after their operation, and this was a really important finding, those who were non-frail, almost all of them ended up going straight home. But those who were frail had 20-fold higher risk of being discharged to somewhere other than home, whether they got a minor operation or a major operation. So this was a really important finding. This is a nested ROC curve that shows you that frailty gives you information above and beyond the other indexes, the other risk prediction scores that we have for surgical patients. And so you see the ASA score, which is a very commonly used score in surgery. If you only have the ASA score, you have much less information about the patient than if you have the ASA and frailty. So frailty is not only independent, but it gives you new information that you didn't have about the patient. So that's in patients undergoing general surgical operations, and that caused us to really be interested in this intersection between surgery, gerontology, and obviously transplantation. So in transplantation, older adults comprise a higher proportion of those considering a transplant and those undergoing a transplant, just like all general surgery. But because our patients have end-stage renal disease, end-stage liver disease, et cetera, even younger adults look like older adults, and I'll show you some data on that. And so risk prediction is not just challenging in older adults, but is challenging in everyone. Now, we have a lot of factors that we capture in national registries, like in the US, the OPTN registry. In Canada, you have registries that capture information about patients that help us build risk prediction models. But frailty is not captured in any national study that I'm aware of. And so 10 years ago, when we became interested in this, we really needed to approach this from a research perspective. We needed to collect prospective data on people entering the transplant system, whether they were frail or not, and to see what the impact would be. In starting to build cohorts, this is what we noticed at first. The bottom pink bar is those who are frail, and then the green bar is those who are intermediately frail. And on the right is the community health study. This is the study that Linda Fried did her initial study of. And these are all community dwelling older adults over the age of 65. And you see that the frailty prevalence is less than 10%. Now, I've split our dialysis, kidney transplant waitlist, and transplant cohorts. We have now about 10,000 patients that we've measured frailty on. And you see, even in the younger age groups, in every one of these cohorts, the risk of the prevalence of frailty in 18 to 45-year-olds is twice as high, at least, as those among community dwelling elderly adults over the age of 65. And obviously, as age increases, the prevalence of frailty increases as well. Frailty is more prevalent among the general dialysis population, a little bit less prevalent among highly selected waitlist population and the transplant population as well. It turns out that as clinicians, we are not very good at predicting somebody's frailty. So what we did is we asked nephrologists, nurse practitioners, and the patients themselves to identify whether they were frail or not in a study of dialysis patients, and then we compared that to actual frailty measures. And the percent agreement was quite poor, 60-something percent among the clinicians, 50-something percent among the patients themselves. And interestingly, older adults and women were more likely to be misclassified, comparing the perceived frailty to their actual measured frailty. So we started looking at the impact of frailty on this population. We looked at prevalent dialysis patients, and of this population, 40% were over the age of 65. So when I'm showing you these numbers, this is an entire cohort, but less than half of this cohort are elderly. 42% of this cohort were frail. And frailty was also, just like in Linda Fried's original study of community dwelling older adults, frailty was independent but overlapping with disability and comorbidity. Frailty also in this population associated with outcomes, just like it did in community dwelling adults. So among frail patients, 3-year mortality is 40%, where among non-frail patients, it's 16%. And if we adjust for age and comorbidities and demographics, et cetera, frailty and intermediately frailty were associated with more than 2.5 times the risk of 3-year mortality in these patients. Also associated with higher risk of hospitalization in the next month when you're looking at somebody who's frail and on dialysis. And frailty was associated with 3 times higher risk that the patient would have a fall in the next 6 months, and a fall that would require medical attention for that patient. So frailty in dialysis patients portends pretty poor outcomes. And interestingly, age was not an effect modifier for any of these outcomes. And what do I mean by this? I mean that the younger patients were just as impacted by being frail as the older patients were impacted by being frail. So frailty is this independent new domain of risk that we're seeing in these patients. When we studied recipients of transplants, only 22% were above the age of 65, because obviously these are a more highly selected group, but still in this cohort, 25% of the patients were frail. And if we looked at early allograft function, DGF was twice as high in those who were frail compared to those who are not frail, and that's after adjusting for all of the comorbidities, demographics, things that we know impact DGF in transplant recipients. And in fact, of all of the recipient characteristics, frailty was the most impactful recipient characteristic, more impactful than age or BMI or race or diabetes, et cetera, et cetera. Frailty was associated with 2-fold higher risk of delayed graft function. Now, does that make sense biologically? Well, if frailty is an inflammatory phenotype, and that inflammatory phenotype is impacting the immune system at the time that the transplant is occurring, then sure enough, it could possibly impact the success of the early allograft success. Also, you know, consistent with the framework that I'm building for you now. Those who were frail had 2 times the risk of early hospital readmission after the kidney transplant, 1.6 times the risk after we adjusted for all of the differences between the patients. And in terms of graft loss and mortality, those who were frail had more than 2-fold higher risk of these adverse outcomes compared to non-frail recipients in a relatively large cohort of transplant patients. Frailty is associated with worse health-related quality of life, so 3 times the odds of either fair or poor health-related quality of life in these patients. And interestingly, frailty is also associated with cognitive function. So we know that there is a risk of delirium after kidney transplants, and that delirium has a bad impact on the outcome of these patients. And we see here that in addition to age, deceased donor transplant versus live donor, Charlson Comorbidity Index, et cetera, frailty was independently associated with 2-fold higher risk of post-transplant delirium. And those who got delirium had longer length of stay, higher risk of being discharged to an institution, higher risk of graft loss, higher risk of mortality. So this may be one of the mechanisms by which frail patients have poor outcomes, because frail patients also have poor cognitive function, higher risk of delirium, and then higher risk of associated complications as well. So we know that frailty is a new domain of risk. It's captured by this clinical syndrome of weight loss, grip strength, exhaustion, low physical activity, and slow walking speed. It can also be captured by radiographic evidence of sarcopenia. I don't have time to get into those data, but there are some recent studies that show that you can radiographically predict somebody's level of frailty by looking at their muscle mass, their muscle composition, fat inside the muscles, et cetera. But ultimately, what frailty does is it captures physiologic reserve in a way that we've not been able to capture it before when looking strictly at disability and comorbidity. Frailty is also associated with poor outcomes in surgical patients, dialysis patients, transplant patients of all ages, not just older patients in these subgroups. And if you look at the outcomes, you can see, as a summary, falls, hospitalizations, mortality, delirium, early graft dysfunction, early hospital readmission, mortality, et cetera, a slew of different poor outcomes that frail patients experience when waiting for or undergoing kidney transplants. So that's kind of what we know about frailty and its impact on patients. What's next? And I'll talk to you a little bit about things we've done in the last year or so in this area. One thing that we want to do is better understand the underlying physiology. So if frailty is an inflammatory phenotype, understanding the inflammatory cascade that causes this may help us, one, get some inferences about some mechanisms underlying our findings in transplant biology, but two, get some inferences for how we might be able to impact somebody's frailty. Another thing we want to understand is the trajectory of frailty. So if you're on dialysis, or if you're cirrhotic, or if you have heart disease, et cetera, does your frailty get worse? Who gets worse? How much does it get worse? Who could potentially get better from a transplant, et cetera, et cetera. We want to better understand cognitive decline and whether it's reversible, and what the relationship is between cognitive decline and frailty. And then we want to try to improve patients' frailty through prehabilitation. So we all know what rehabilitation is, and the new concept is, can we, because these patients are sitting on a waiting list, it's not like a surgical patient who needs their appendix out and we have to take their appendix out today, and if we don't take it out today, we're putting them at risk. But our patients can often wait for months to years prior to a transplant, and during that time, can we improve them physiologically? And I'll show you a little bit of data for that as well. It turns out that frailty among older adults in the models that Jeremy Walston and Linda Fried had worked out is an inflammatory phenotype, as I told you. And you can look at inflammatory markers to see whether they relate to frailty and their impact on outcomes of patients. And what we found is above and beyond frailty itself, you can learn a lot about somebody by looking at IL-6, C-reactive protein, and then this thing called an inflammatory index, which is a combination of these inflammatory biomarkers. And so what we have is if we measure the inflammatory physiotype, we can actually get information about that patient's physiologic reserve just by looking at inflammation. When we follow patients after a kidney transplant, it turns out that in the first month they get more frail, as one might expect because they underwent a bigger operation. Things seem to sort of settle out by 2 months, and actually by 3 months on average, patients are getting less frail. Now, we're starting to better understand as we do this in thousands of patients that there are some patients who will improve from a kidney transplant and some patients who will not improve their frailty after a kidney transplant. And better understanding who will improve and who won't improve will help us, one, in determining who is at highest need for prehabilitation, and two, who we should just give up on and say, look, they're too frail and doing this transplant is just going to hurt them rather than helping them, versus who's frail, but as soon as we do the transplant, all of that physiology will reverse. I told you about cognition and the risk of delirium post-transplant. One of the things that we're doing now is we're studying overall cognition in patients who are on our waiting list to see if frailty impacts cognition, and then if we can, using prehabilitation and other cognitive and physical exercises, if we can reverse that. And what you see here is that among non-frail patients who are on dialysis, their cognition stays about the same. But among frail patients, you see that after so among non-frail patients, I'll walk you through it a little bit more. Among non-frail patients, prior to the transplant, we see a change in cognition, but then immediately after the transplant, we see improved cognition, and then we see that sort of slowly improve over time, but really not a major change. But in frail patients, we see at some point post-transplant, presumably because they've become particularly frail, we see that cognition actually can decrease over time. And these are the patients where we really want to intervene. Can we intervene? This is a physical prehabilitation study that we did, where we took people who are on our waiting list and we gave them prehabilitation and we measured their physical activity. And you see the blue line and the red line is at baseline, and after the first month of prehabilitation, you see that pretty low physical activity in these patients. But when we get to 2 to 3 months, they have substantial improvement in their physical activity just by undergoing some physical prehabilitation. Some ideas for prehabilitation: we've put exercise pedalers into dialysis centers. Since they're already stuck there on dialysis, they might as well pedal a little exercise bike to see if they can get a little bit of physical activity. And then we also give them cognitive activity with iPad cognitive games to see if we can improve their cognition. Now, this is among those on the waiting list. Of those who got transplanted from this pilot randomized controlled trial, we saw that length of stay was half in those who underwent prehabilitation versus those who did not undergo prehabilitation. So indicating to us that there is some way to improve people's physiology prior to the transplant, and transplant patients are an ideal ideal population for this, because we don't even get the privilege of doing their operation immediately. We have to wait until donors become available, which gives us time to prehabilitate them. This is preliminary data, pilot data from a randomized trial. We have a large NIH-funded randomized trial underway now, so hopefully in the next year or two we'll be able to have more data than that. So I'll stop here and then give us some time for discussion and to talk about the frailty concept and the concept of studying geriatric patients and transplantation, et cetera. But I'll say this: by collaborating with geriatricians, by collaborating with people who are used to taking care of and studying patients who have multimorbidity, lots of different reasons for having poor outcomes, comorbidity, disability, etc., we were able to discover this construct of physiologic reserve that we had not thought about in transplantation prior to that kind of a collaboration. Working with the geriatricians has helped us not only understand older transplant candidates and recipients, but also understand younger ones, because in our population, there are certainly 40-year-olds who have the physiology of 75-year-olds. And so understanding younger patients through these geriatric constructs is actually really important as well. Frailty is a strong predictor of adverse outcomes in dialysis patients, in waitlist patients for kidney transplantation, and in post-kidney transplant recipients. A good friend and colleague, Jennifer Lai at UCSF, is conducting a multi-center study of frailty in liver patients as well, and we're finding very, very similar results in the liver population also. There is some interesting physiology that goes on with frailty, including inflammation and revving up the immune system, and that obviously integrates with the immune modulation that we do in transplantation. And as a result, we've seen some of the impact of that inflammatory state when we give the patient a new organ. And we are now working to better understand how to measure frailty in different diseases rather than just community dwelling older adults, and what the impact is of inflammatory biomarkers in these patients, what the relationship is between physical frailty and cognitive dysfunction, and then also how to improve somebody's frailty through prehabilitation in the hopes of improving their outcomes after a kidney transplant. This is my research group at Johns Hopkins. I'd like to acknowledge a lot of the folks in this group who have been helping me study frailty for the last 15 years, and in particular, Mara McAdams DeMarco, a PhD trained professor of epidemiology, and really the person who took studies that we had in early stages and built them up and ran with them, and really has helped the whole transplant community understand the concept and implications of frailty. And I am glad to open this up for discussion.